Let's see. I am not. Just getting all of the snags out this morning. Those of you that are members to the NCA site, you've got my Zoom link and can join us over here. As I was saying, we had a lovely meeting 2 weekends ago in Dallas for the R2P symposium. Thank you to Parker University for hosting us there. It was my first time actually going to Parker and seeing what they've done to the place. Their gym facility there and their strength coach degree is pretty impressive. Cody DeMack, Jeff Barron, Marianne DeMack, all wonderful hosts for us there at Parker. It's also great to reconnect with Brett Winchester. It's been a minute since he and I have spent some time together, and I did a podcast with Brett and his organization there. And then last week, for the first time in the driver's seat, flying solo for one of the NCA courses, I taught the lower quarter course in Seattle, hosted by Seattle, by the Carly Causey and Kelly Henry, a couple of former R2P students at Western States there. And we had a lovely group and some good case studies and all. You guys that were at the course, any thoughts this past week? Any notables? Any cases that you ran into that you were like, well, that's different?
I had two cases that I had new insights on, I guess would be a good word. And both of them were anterior, it's not like we live in a perfect world where I can make a perfect diagnosis, but at least, one is 80s. I'm going to present these cases briefly. Is that okay, Philip?
Sure. Well,
okay. One is a 80-something-year-old woman has been a patient of mine for a while, and she has become frail. And she went through she had both a thoracic and an abdominal aneurysm, and ended up with, 2 surgeries and then a third surgery because there was a leak. And for all of those surgeries, they inserted the surgical instrumentation up through the femoral artery in the groin. And it was like I had an aha moment of, oh, this is a significant part of why she has this pain that she's very vague on, that is both a back pain. She happens to also have an L5 discogenic pain, sciatica, that we can get under some control with a lumbar nerve opener. And she does the lumbar nerve opener differently. What she does is just she's sitting and bending into flexion and away from that side rather than laying on her side, because it's hard for her to get up and down. But so we kind of sort of have some answers for the L5 one, but the other pain was very confusing to me until I realized, oh, this is coming from the damage to her, what's that word you use, that P word?
I don't know, mate.
No, the one where you think it's this. So anyway.
Oh, putative. Yeah, putative.
Yeah, she has putative issues with these anterior lumbar nerves. And one of the things about my skill set is I was a serious student for quite a while of Jean-Pierre Barral's visceral manipulation. So I'm very comfortable putting my hands on the abdomen, and I don't need to push very deeply into the abdomen to assess deeply in the abdomen. That's the way the French guys do it. They just put their hands on, they listen, and they can move things around without, sinking 3 inches deep like massage therapists do to the psoas or something. But anyway, so I'm still not, I don't know if a femoral nerve glide is going to help this lady or not, but tuning into that's a significant part of her pain has been a valuable thing. The second case is a 68-year-old woman who historically has been very, very fit. And she had a weird injury a year and a half ago where she was walking down a hill and had sudden onset severe anterior groin pain. And she's been worked up for it and has had x-rays. I think she's had an MRI. She saw a whole series of massage therapists and chiropractors. And one of the things she said was, one of the intuitive massage therapists put their hands on my belly, and that seemed to be significant. So the other part of her history is that she was in a foreign country and ended up with gut pain, which turned out to have been appendicitis, and they didn't do surgery. And then a few weeks later, her appendix burst, and they finally did do surgery. But she ended up with severe peritonitis. And, I haven't looked at her inside of her gut, but there's piles of scar tissue there, clearly. And when I touch the right side of her abdomen, mid and lower abdomen, it's very, very ropey. It just feels very weird. And it feels totally normal on the opposite side. And so I started doing CFM, cross fiber, to the putative iliohypogastric nerves going through the abdomen. And that felt useful to her. The other thing that happened with her, I'd been really skeptical of your get up out of a chair test for the upper lumbar nerves, but I had 2 cases where I missed weakness doing manual muscle testing of the hip flexors and the knee extensors. But when she tried to do some kind of single leg squat on that right side, she was very, very weak. The other thing I think I helped her with was, I went through scouring her hip and rotating her hip. Her hip moves fine, and it helpful for her to hear that her hip was not the problem. So sometimes we help people not by what we do, but by what we say. People really listen to us, But anyway, she had stopped doing squats and wasn't doing any gluteus medius exercises because she was afraid that she would hurt herself. But this is a lady who walks up and down steep hills, at least did before she hurt herself. So getting her restarted on single leg squats of some kind, and getting her started on monster walk band exercises for the gluteus medius, I think is a big help. And then I'm hopeful that a few sessions of releasing the abdomen may make a difference for her. So those are the cases.
Cool. Thanks, Mark. Appreciate you sharing those.
And one of the things I realized looking at anatomy this morning is the iliohypogastric ilioingual nerves are not part of the femoral nerves. They come up a little higher. They're lumbar plexus nerves, but you got to get down lower to get to the femoral nerve. That's more L3-4. So I keep learning more anatomy. And the slides from that class were wonderful. Thank you.
Awesome. Thank you, Mark. I appreciate the feedback there as well. Let's see. Since it's been a couple of weeks, I wanted to go back and touch base. Those of you that haven't seen them, and even those of you that are over here on Facebook, you can go back. We record each of these, and you can go back and see the recordings on at neurocentricapproach.com/blog. So the blog tab on NeuroCentric Approach is where these these cases will live. And if you go back in those, there were a couple that I wanted to touch base on that I saw, and just so that you know that I'm not always successful, just like you. The 71, 72-year-old female with sciatica after the arm or the fracture of her wrist, ostensibly thought to be due both by me and also by her orthopedic surgeon, to be due to her hanging out in a right lateral bend. She had right-sided sciatica, in a very protective position for a good period of time. And that right lateral bend, to my mind, over time started to create a closing phenomena there at the IVF, and basically just making her aware of that and showing her opening procedures in sideline, sitting, and standing, enabled her to get off of that nerve in the first week, enough to have remarkable change. And she walked back in looking like an entirely different person the next week. She felt so good, and she is an ardent Portland Trailblazers fan and season ticket holder, that she insisted on going to a game with a friend. And she went to the game and had a very large human being sitting right next to her on her left side. And she felt the entire game like she was pitched off to the right to try to avoid them. And long story short, she came in the following week and she was right back to zero again, and massive pain in her right sciatic nerve. So she was also on board. She is a chronic smoker of a pack and a half a day, and she drinks quite a bit of alcohol. And she was fond of calling my office number after she'd had a couple of drinks in the evening, and was noticing that her leg was still painful, and she would call me up and cuss me out in the middle of the night. Blessedly, that's why the baby Jesus made answering services, I guess. But I ultimately I've sent her back to her primary to consider a Medrol pack or something to get her symptoms under control. So sometimes we have to pivot on those. The other one that I want to bring up and go back and recap, you might recall one of the recordings that I did of a intermittent incontinence patient. This was a former Marine with a 3-level spine, lumbar spine fracture. And for 10 years or more, he'd had intermittent incontinence with what he described as a long step forward with the left leg. He's working in a construction company and basically oversees the bidding process, and mostly a general, if you will, in those circumstances. And when he came in, he could get a threat of urinary and fecal incontinence by stepping a little bit further with his left leg and then abducting. So like stepping forward and around something, like he would possibly be doing in an attic or something of that sort. I wanted to come back and update on him, and he is doing really wonderfully. He's not had any further incontinent episodes. We have worked a model of threat due to lumbar functional instability, and have steadily been working on improving his deep spine stabilization system using some, call them I won't say esoteric, but moving tangential to DNS and then more specific to his job kind of stuff. Now I've got him doing shuttle runs, box jumps, dynamic lunges, scissors lunges, where he jumps and lands in a, does 180-degree movement in the air and then lands. So he's doing really quite a lot better. And his longer term goals are to rock climb and return to golf. So we're in the process of that. For what it's worth, in the DNS world, Giancarlo Russo, I was always impressed with his reactive kinetic cueing that he would do, which I particularly was more fond of than the predilection for a lot of the DNS systems internal cueing strategies. But I like to use things that cause a reactive stabilization strategy using deep spine stabilization. And in this particular case, we had those, hell, I don't even know what they're called. I think they're called mobility sticks, those orange things with the black rubber ends on them. And we've got some of those at our Kabuki establishment. And when I took him out on the gym floor and used that for reactive cueing and had him grab it in the middle. And we had a good fun time of doing walking lunges, which initially caused pain and back pain and also that kind of squirrely incontinence sort of thing. But I'd have him to shake it back and forth, kind of like one of those body blades that some of you might recall. Yeah, stick mobility. Thanks, Capo. Hope you're all right, buddy. I missed you when I was down in Dallas area. I was hoping you were going to be there. But he would shake that, and as he was shaking the stick mobility thing, he was able to lunge with absolutely no pain. And then there would be a carryover in that as well. So we've been playing with that, and it's like, all right, I want you to imagine you're doing a haka and you've got the stick mobility and you're threatening the tribe. And we got down, he'd had some Muay Thai in his background, so we would practice things that looked like Muay Thai movements, bringing the knee up while he was walking. And if nothing else, all the other very thick power lifters that were in the room training, they get a good chuckle out of the work that he and I do together. So that one's been going well. But I got a new case this past week that was particularly fun. Patient presents as a 52-year-old female arson investigator with a 10-year history of left gluteal pain, made worse by prolonged sitting, prolonged standing, and past health history significant for just before her symptoms began in the left hip, she had a bunionectomy on that side. And she noted that she was limping around and wearing a boot for several weeks, and that she felt like that was impactful. She had in the years after that, she had several episodes of treatment from chiropractors, from physical therapists. Her spine had been MRI'd and she was checked out there, and that was kind of ruled out by her other docs as being an issue there. Notably, she had actually presented him in our office and was seen by Dr. Peterson before he left us. And Corey saw a flexion intolerant pattern and was able to reproduce her symptoms using that and put her on some extensions, and she seemed to improve, at least temporarily. Her big change in life came 2 years ago when, on an investigation, she had a horrible fall and a previously arthritic knee, same side, same left side. She had a horrible fracture of the knee, to the degree that surgeons did not feel that it was between that and the prior osteoarthritis. She did not feel that she had, they did not feel that they had a joint that was salvageable. So at the age of that time of 50, she had a total knee replacement on the left. The surgery did not go without complications. In the post-surgical period, she had everything was going along fine, but then she developed what appeared to be a secondary infection and a lot of fibrosis and restricted range of motion in the joint. They had to go in and do a revision surgery, scrape out a bunch of fibrotic tissue. And long story a little bit short, the net result of that was they improved her range of motion in her knee, which prior to that revision surgery she only had about 30 degrees of flexion. They improved that between the surgery and subsequent rehab to somewhere between 90 and 100 degrees of flexion. And after a year or more of dealing with that, she was fine with that. She was like, I can squat and get on and off of the toilet, and I can get in and out of a chair. But, for a previously very active 52-year-old, those are a lot of concessions. Again, her presenting complaint is the intermittent pain that she would feel in her left butt. So let me pull her chart up here. Let's see, an exam. As she was walking into the room, I noted a toe-in gait on the affected side. Those of you that were at our recent lower quarter course, you might recall that that is a bit of a clue to potential version issues in the hip joint. And typically, toe-in gait is a compensatory gait for an anteverted hip. So I noted that and kind of stuck that away to do a Craig's test while I was in the treatment room. With her top tier range of motion, she was fine in flexion. She had full range of motion and no reproduction of symptoms in the left glute on flexion or extension. But on left rotation, she had a reproduction of her symptoms. And to my mind, if you think about that left rotation, as you turn to the left, almost like, a follow through on a golf swing, as you twist to the left, you weight the left foot more and you effectively internally rotate the left hip. So again, bing, 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 I'm thinking, version issues in that hip and flagging that away for my prone examination when we get to that and supine examination. Working through our physical, she had a positive seated slump test on the left side, and that reproduced her presenting symptoms in the left glute. And those symptoms were modulated by both ankle movement and neck movement. So I know then that I've got some mechanical sensitivity along that neural tract, and I know that I'm looking at a butt pain of some sort of neural origin, but I don't know where. So continuing on, her seated compression test was negative. So that lead me away a little bit to from a possible bulging disc etiology there. However, and when we did prone press ups, we had no change in her symptoms. Before that, let's see, her motor, the repetitive single leg heel and toe stands, and the repetitive single leg sit stand were W and L throughout. So she had normal motor function for L4, 5, and S1. When we, even though we got no benefit on the prone press ups using playing an MDT card for a putative spinal origin butt pain, ridiculous symptomology there. I always like to follow up with one more intervention there at the spine to make sure that I'm not overlooking something. I did static openers, and the static openers slightly improved her slump index position. So I noted that, but it was about a 20% improvement on that, not a huge one. So now I'm thinking, maybe there has historically been a little bit of something going on at the spine that's sensitizing the sciatic tract, but my index of suspicion is a bit lower there, and I'm suspicious that there's something going on further downstream. So as you guys learned in the lower quarter course this past week, we then shift our attention to the sciatic nerve, but we move downstream into the glutes and do our deep gluteal pain screen. We screen I screen the piriformis and the seated piriformis stretch, which most of you recall is seated, passive internal rotation of the involved leg, and then adduction of the leg. So essentially the same internally rotated position that I saw on the toe end and on her left trunk rotation and standing reproduced her index or caused pain in the presenting left hip. So that was kind of interesting. I also found some mild positives with the ischiofemoral impingement test. And then I didn't have any reproduction of symptoms with the hamstring tests, and she had no prior history of hamstring pathology to raise levels of suspicion there. When I did my palpation along the sciatic nerve, I was able to make symptoms in the downstream glute, palpating the sciatic nerve at the sciatic notch. So now we're up above the area of the putative entrapment or problem in the sciatic nerve, the interface issue between the sciatic nerve at the piriformis area and the so I'm above that in the sciatic notch, and she was tender 3/4 on that side versus 1/4 on the right, the unaffected right side. Okay, so to my mind, that's like, okay, maybe there is something going on upstream at the spine, and that's what we were seeing with static opener, and that would make her relatively normal, probably some spondylosis or something of the sort. In a 50-year-old with a fair bit of life lived. But I was thinking the primary issue is likely the sciatic nerve at the level of the deep gluteal space, somewhere between the piriformis and the underlying structures there. Now, many of you will recall that went to the course will recall that there was an interesting situation there. Let me see if I can pull it up. I will share screen and try to pull up the course notes here and review it for you. Give me just a second. Yeah, that's our slide there. All right, let me get over here to screen share. All right, you guys able to see my screen there? And you might recall that we talked about the variety of entrapment possibilities for the sciatic nerve over the in the area of the so-called triceps cocci, and that's that Italian deli in your butt. That's the superior gemellus and the inferior gemellus sandwiching the obturator internus. And at that level, you might remember this slide in your notes where here they're demonstrating internal rotation of that femur. You can see here is neutral or externally rotated, and here there's internal rotation. And what they're showing is this structure here that you may be able to see, which is a fascial mat that overlies the sciatic nerve and tethers the sciatic nerve to these muscles, the superior gemellus, the obturator internus, and the inferior gemellus, such that when you internally rotate the femur, that draws the sciatic nerve down on top of those structures and presents a potential entrapment point there. And that is just underlying the piriformis muscle. So now I think I've got some ideas of a possible mechanical interface problem beneath the piriformis, possibly involving the piriformis, but also possibly involving that fascial mat over the triceps cocci. And that is what I might be seeing with that internal rotation and the testing that involved internal rotation of the femur with her standing left trunk twist with the seated internal rotation and adduction of the femur. If true, then probably that individual with that toe-in gait would have a worsening of symptoms if she walked a lot. I didn't have that in the history anywhere as a potential provocation, so I'll investigate that again next visit. But that, I think, is probably the origin of the symptoms in her butt. I did some deep cross fiber friction work right over that area and briefly worsened her symptoms, but later she reported that they were improved and gave her some ways of continuing that at home and then doing neuromobilizations after that. So basically the 1-2 punch of doing the manual therapy and then the mobilizations on the back end, if you can't get all of that done in the same situation. On her static openers as well, I also had her doing with the affected top leg, had her doing neuromobilizations while she was doing the static opener. Now, here's the fascinating part. Many of you recall when we got to the theory that we're working about improvements using a neurocentric approach, improvements in our joint mobilization and manipulation procedures by paying attention to the orientation of the collagenous structures in the involved joint and the orientation of the involved sensory articular branches of neurology and how they play with those collagenous structures, then we can get into that collagenous structure and theorize a way that we can potentially place tension or flossing mechanisms on that involved neurology, and possibly even dependent on the joint and the area that we're working on, possibly even get down to that level and try to affect a transverse nerve mobilization or cross fiber friction on the path of that particular nerve. So I feel a lot more comfortable with that work in the hip, but remember this patient also had a TKR. That's total knee replacement, Mark. Her total knee replacement and the subsequent revision, she had problems restoring her full flexion of the knee. And when I asked her, when she tried to flex her knee beyond about 95 degrees, if she felt anything, yes, she felt pain on the anterior side of the hip. Okay. Now, recall, those of you on Zoom can see this one. Those of you over on Facebook, you can see us over on Zoom. If you go to the NeuroCentric Approach Online Academy and you take advantage of the crazy value there and you become a member of the online academy and get 30 hours of continuing education online there for a one low price periodically. But anyway, over here, you guys recall in this image that the as I was palpating her in supine, palpating the knee, I went in and did a screen to see if I could clearly find at a superficial level something that was interfering with that full flexion of the knee. And remember how we do our graded assessment is to start from just looking, and then we move to a DTM or very superficial rule out by lifting skin in the area. Then we go to a deeper level and thinking about the neurology in the area, we try to move it laterally to do a transverse nerve mob and see if we get any buy-in. And if that doesn't work, then we go in at a deep level and do cross fiber friction. So I'm still at the assessment stage here. And I went through at the supromedial compartment and did some DTM over the course of the saphenous nerve. You guys know I'm bullish about saphenous nerve causing some issues there. No change. No change. Nothing at the adductor canal further upstream. Nothing at the lateral patella. Nothing at the infrapatellar, infrapatellar branch of the saphenous nerve. So, okay, that is femoral nerve on that side. And then I went over to the more superficial nerves on the other side. I did a little quick tug on the bottom, on the inferior portions of the knee, both medial and lateral. I didn't get any buy-in at all, but when I went in over the superolateral compartment of the knee, and again, supine patient, on one hand, I'm working the knee, and the other hand, I'm using to try to create some space for any nerves that might be pissed off in that area. And when I got in that area, I noticed a little bit more give in the knee. And I was like, okay, so I think I might be in the right quadrant of the knee. Now, let's think about all of the neurology that services the superolateral compartment of the knee. If we go to our course notes on that, let's see. There's the supromedial, inframedial, superolateral compartment. Here we go. Here are your list of involved nerves from essentially superficial to deep here, of potential nerves for that provide articular sensory innervation to the knee and the superolateral compartment. And of these, note that we've got femoral and femoral. These are more superficial, the nerve to the vastus lateralis, nerve to the vastus intermedius. You guys also recall that I, in the course, was suggesting that I was a little bit skeptical as to whether or not we can even get into these deeper nerves that are the like the geniculate nerves. And you might even recall that I was considering pulling this from the notes, because I'm thinking, even if this is a thing at the knee, that my ability to get to something that's deeper, like the superior lateral geniculate nerve, is highly suspect. So despite all of that, I saw what I thought to be an improvement by working a lifting mechanism in the superolateral compartment. So then I went from a DTM to a deeper palpation. And as I moved deeper in the superolateral compartment, I could find some ropiness in some deeper areas. I went into those, thinking of them most particularly as the nerve to the vastus lateralis. You might recall that some of the studies that I cited suggest that we've pretty consistently, this is what we're looking at, and that sometimes we've even got the deeper branches coming up and communicating with these from sciatic to femoral, so we can have some communication there, and that's kind of fascinating. But when I did that at the intermediate level, I got no real significant change in the ability for her passive knee flexion to improve. But then here was the cool part. I went into that little divot. You all can kind of put your fingers on your knee yourself if you're sitting right now, and get on the lateral aspect of the knee, and then get on the anterior aspect of the iliotibial tract, track over to the vastus lateralis, and feel that divot right there, right? And that's the divot that I was in. And even if you've got big honking gams like our like Kyle Hemsley did at the course, you can still get pretty deep right there. So I worked into that area with my thumb, thinking about the course of the superior lateral geniculate nerve. And when I got down in there, there was a ropey area deep and just felt really gnarly and fibrotic. And when I got on that and shoved it medially, I shit you not, she had 30 degrees almost immediately of increased flexion in the knee. And it's always fascinating to see these times where you find a restriction that clearly has been impactful in this person, and you see the reaction of the body to that. And I'm, as I'm working in there, I'm watching her face and watching for any clues from her face for what she's giving. She was holding her breath. It was like she knew that I was on something important. She knew and could feel her knee moving. and she couldn't really believe that her knee was moving. And you could see the tears starting to well up because she didn't want to get too hopeful about the possibility that she could have improved range of motion in that knee. And I just smiled at her, and she kind of smiled at me. And I said, "You can feel that, right?" And she said, "I didn't think I would have movement to this degree in that knee again, let alone this quickly." So that was really cool. Who knows what structure I'm in? I'm going to be intellectually honest, but I also have to have a narrative to guide both me and my patient here. But I think I was working over that superior lateral geniculate nerve. Whatever it was seemed to be important in her ongoing inability to flex the knee. I did the TNM and then ultimately went and did over that lateral point that we all know and love from some of the other myofascial techniques out there, did some elbow work over that. And she had about 30 degrees of improvement in her squat depth and in her passive flexion at the knee. And she was just over the moon. She was very skeptical coming in that there was going to be any benefit. She was sent in by other people that have been seen in our office as well, in addition to having previously seen one of our docs. So that was kind of cool. What I learned out of that as well is I don't think it's time yet to throw this articular approach with the knee out. I've got to explore it more for the shoulder. I think the hip is pretty good, and I see consistent benefit in the hip. Working mobilizations that take into concept or take into consideration the collagenous orientation of the fibers in the joint and the articular branch sensory innervation in the joint. And also worth noting, where did we find that her symptoms in her hip were oriented around what neural structure? Sciatic nerve. And what is the, even though it's on the anterior aspect of the knee, what is the origin of the superior lateral geniculate nerve? The sciatic nerve. So I think we might be on to something there. Not sure, but I'll keep you guys up to date on that one in future weekends. So,
Philip, can I make one little comment?
sure, go with it, Mark.
So Barral used to teach these, Jean-Pierre Barral of visceral manipulation would teach these incredibly subtle palpations, some of which I never felt like I could get. And I think you're saying, hey, here's some structures I know that all of you can palpate if you work at it. And here's some structures you may or may not be able to. But a case like this, if you didn't mention the superior lateral geniculate nerve coming off the sciatic nerve, you wouldn't have helped her. So, even if we're not sure, it's worth leaving the option open. Enough said.
Yeah, I agree. The other thing that I think is probably worth noting here is as eggheady as we want to get on all of this, there was a time early in my career when I was, fascinated by Graston technique and doing a whole lot of instrument-assisted soft tissue mobilization using those tools, that I would throw Graston at damn near everything. And I would have taken those tools in this patient and done an exploration with that handlebar tool, and I would have done it over the knee and see if there was any benefit. And probably with that tool, I bet I would have gotten down and felt some of those ropey fibrotic areas that I, thought I was being a little bit more specific in finding with my fingers at this point, 20 years later. But I probably would have gone in there with the screen, found those areas, chosen a different tool and gone into that area and opened it up. And you know what? I bet it would have helped. And I would have had an entirely different narrative to explain it that would have involved fibrosis and releasing things. And all of those those types of narratives really suffer under current evidence to suggest that we're at the collagenous level, we're not releasing anything. What I think we're doing, and again, what I was really trying to get you guys in the course to focus on, is not so much about the structure of the nerve itself or even the structure of the fascia, but the intersection of those two. That interface is the important part. And I think by tugging on a nerve or by sliding a nerve or by shoving a nerve sideways and then loosening up the tissues in that area, read high hyaluronic acid, viscosity, or whatever, then I think we can change that interface. I see Robert Libby on here as well, and Robert teaches some as a massage therapist, teaches some excellent coursework on ligamentous trigger points and things. And I wonder if that might be what we're talking about here with these collagenous structures at the joint and the embedded sensory articular branches of the nerves in those areas. My suspicion, as well as I've told some of you guys, and I'm still not ready to take this out to prime time, but my suspicion as well is those sensory branches of nerves that also contribute innervation to the tenosynovial sheath around a variety of tendons. And my suspicion is that if we've got upstream sensitization of neurology that downstream provides articular branches to a joint or sensory innervation to a tenosynovial sheath, that may somehow contribute to the sort of misfire, if you will, of a tendon injury that does not progress normally from a tenosynovitis to the retraction of the sensory neurology out of the tendon after 2 to 4 weeks, which we would normally see under normal conditions, and thus progressing into a tendinopathy. So I just kind of wonder about that. That almost is in line with the so-called information theory of aging, with the idea that basically our immune system is so caught up dealing with the oxidative stress throughout the organism that we lose the ability to do some of the cleanup, if you will, that the peripheral nervous system and the immune system is designed to do. So we will continue to investigate all of those things over time, since they all come under the heading in my world of neurocentric approach as well, those cellular aspects. And we'll keep talking to the researchers and see what we come up with. We are 1 minute away from closing time here. I get a note here from Robert, who also is a member here at NeuroCentric Approach. It says, thanks for the shout out. Yes, I have found that the NeuroCentric Approach blends very well with the LAS techniques. I would love to have a copy of your book, Ligament Pain Referral Patterns. That's by Robert Libby. That's Libbey. And you guys can find that at www.ligamentpain.com. Robert Libby. And Robert, you were at the Fix Your Own Back course that I taught in Vancouver, I believe. Were you not? Didn't we meet there? Pretty sure that was the case. At some point, it would be fun to come back up that way. Cool. That was September 2018. It would be fun to come back up there in the not too distant future. Other courses that are in the works, Glenn Harris, who is on here, we've got some dates we're exploring in November in Toronto. We are in the finals of getting a course in St. Louis with Scott Grogan. We are looking for a venue in the Minneapolis area. We've got quite a few people in the upper Midwest from North Dakota, Wisconsin, Michigan that are interested in the material. Jeff Barron and I are talking about bringing one down to Phoenix. So there's lots going on behind the scenes to get another course going. And but our next one is oh, thank you, Robert. Robert says the Fix Your Own Back course is one of the best courses he's taken in 30 years of practice. Awesome. Might have to break that course out again too, huh? Our next course, Portland. Mark's going to be there. Saw you signed up yesterday. Cool. You guys can go to NeuroCentric Approach, look for the events tab there, neurocentricapproach.com, and find the registration page for that April 2021, 20th and 21st date in a couple of months, and join us there. And I look forward to seeing you there. Once you get both of those in-person courses, we'll get you on the locator map on a NeuroCentric Approach. And as the word gets out and people start looking for it, you can distinguish yourself in your neighborhood on that locator map by being one of the few people that are apparent on that. Okay, last chance. Any questions, comments? Mark, go have a good walk, my friend. Take care, brother.
Everyone, have a good night.
All right. That is it then. I'm going to go for a nice long walk with my doggy and listen to an audio book. I hope you guys have a wonderful, wonderful weekend. And in the meantime, stay curious, use your curiosity, go out there and help some people. Be well. Take care.
Have a good one, Phil.
Thanks, Ryan.